Well, thanks very much, and welcome to all of you on this afternoon. Joining this ICUS webinar on contrast-enhanced ultrasound safety expert analysis. First of all, just like to extend a warm welcome to all of you from our ICUS co-presidents, Dr. Steve Feinstein and Dr. Stephanie Wilson. And we'd also invite you to check out our website at icus-society.org. Go to the next slide. The International Contrast Ultrasound Society is committed to contrast-enhanced ultrasound. We know that CEUS is an essential tool for modern ultrasound labs. It's safe, reliable, versatile, patient-friendly, and cost-effective. And it produces high-resolution, real-time images, not just the cardiovascular system, but the larger vasculature, many organ systems, and also tumor perfusion. And we also know, based on published data, that CEUS oftentimes will reduce the need for downstream testing. It improves hospital workflows and speeds access to diagnosis and therapy. In advance, we're the only global professional society which is solely focused on contrast-enhanced ultrasound. We now have members in 74 countries across multiple specialties and really all major disciplines as well. We're unique in that membership is actually free. And if you'd like to do so, you can join right now using the QR code on the slide and take advantage of other free CME opportunities, just like this one today. Take advantage of our free mobile app and also the ICUS Contrast Enhanced Ultrasound News Monitor, which is emailed to all ICUS members on a regular basis. And if you go on to explore the ICUS website, you'll find our 2025 webinar calendar, guidelines, protocols, and training materials, and information on how to establish your own contrast-enhanced ultrasound lab, as well as coding information to enhance reimbursement. I mentioned previously the CEUS News Monitor, which is emailed free of charge to all ICUS members, and you can also access our free mobile app using the QR code there for both Apple and Android devices. You can go on to the next slide. We'd also invite you to check out the Sonographer Training Resource Hub. This was developed by a joint multi-societal task force. You can see all the societies which were involved listed there, including, of course, ICUS as well. We also offer something very important, that's IV training and certification. Obviously, development of a CEUS lab is heavily dependent on the ability to inject those agents. And this is critical. You can see here the part 1, part 2, and then pending certification, which is around the corner as well. And this is available for both echo and general imaging sonographers. Also like to call your attention to a new ICUS multi-societal consensus statement on the safe administration of ultrasound contrast agents, and that was led by one of our speakers today, Dr. Jordan Strom. I believe that's currently in press. It'll be available soon and will be of great use to everyone interested in and participating in contrast-enhanced ultrasound. We would like you to tell your colleagues about ICUS as well. And we'd invite you to also, and them, to follow us on social media. We have a presence on Instagram and Facebook, and you can follow us by using those QR codes on the slide. And finally, something of great importance, and that is our 2025 industry supporters. They're listed here at the diamond, gold, silver, and bronze levels: Bracco, GE Healthcare, and Lantheus. You can see the other silver and bronze sponsors listed there. Presentations like this and everything that we've discussed so far would not be possible without their generous support. With that, I'll turn things back to Matt to get us underway.
Well, thank you so much, Dr. Main. Our first faculty speaker, and it's a real privilege to introduce Jordan B. Strom, MD, MSc, FACC, FASE, Associate Professor of Medicine, Harvard Medical School, Director, Echocardiography Laboratory, Beth Israel Deaconess Medical Center, Boston, Massachusetts. Dr. Strom.
Well, thank you, Matt, and thank you again, Mike, for the wonderful introduction, and really can echo all that you said. ICUS is a wonderful organization and would encourage everybody on this call to join and learn more about this topic. Today, my job is to talk to you about the safety considerations for ultrasound contrast for echocardiography. These are my disclosures. So there's lots to talk about utilization and the benefits of contrast, but here one of the critical aspects of contrast use is, of course, the safety of these agents. And it is known that in general, ultrasound contrast or ultrasound enhancing agents, as they're sometimes called, are associated with about a 1 in 10,000 to 1 in 15,000 rate of an anaphylactoid type of reaction, which can be a severe reaction. It is anaphylactoid, not anaphylaxis, in that you don't require any prior exposure to contrast in order to have it. So it could be somebody coming in off of the street, their first exposure to contrast, and it's felt to be mediated through the complement system. Um, it presents just like anaphylaxis, and I'll go through what that presentation is. But because of this, it is the IAC policy and its policy of many organizations to have a policy on early identification and rapid responses to these severe responses. All personnel, and that includes whoever you are and what your capacity is in working in a lab, whether or not you're a sonographer, a nurse, a physician, a physiologist, otherwise, should be trained on the early identification and in rapid response to these reactions, as you might be the first presenting person dealing with them. And then in general, we recommend allergy kits to be made available and accessible to people. And over on the right is a picture of what we have as an allergy kit at Beth Israel Deaconess Medical Center. We keep these locally in all of our sort of major centers where we do major labs where we do a lot of contrast administration. Of note, the allergy kit has things that are not necessary in your code cart. So the code cart, for example, has a dose, a concentration of epinephrine. Typically, that's sort of 1 in 1,000 versus 1 in 10,000, and you see in the EpiPen. There are things like saline start kit or IV start kit, saline bags, glucagon, other things that may be in the allergy kit. It may not be in your code card. So it is a nice thing to have if your lab can have one of these, and they should be accessible to use from the staff. Most of these really do occur pretty early on. They occur within 30 minutes of use, present as skin erythema, urticaria, rash, throat, shortness of breath, throat tightness, flushing, dysphagia, which is trouble swallowing, or shock. And in general, there are minor allergic reactions that people can have. Temporary back pain is not a allergic reaction, but is felt to be potentially related to retention of microbubbles in the glomerular capillaries, and therefore dilution can be done to sort of mitigate that risk of temporary back pain. If appropriate, people can be treated with over-the-counter NSAIDs and warm compresses, and it will resolve. So a couple of the more common. So a couple of slides just to go through the more common type of appearances of these lesions. So urticaria, otherwise known as hives, typically appear as raised, pale, or slightly red-colored wheals on the skin. The sine qua non of these is they're typically transient. They can come and go within minutes, and they're typically very itchy. If you apply some pressure on the surface, they typically also blanch to pressure because of their vascularity, and they respond very well to antihistamines, IV Benadryl or otherwise. If you have urticaria and you have vital instability, that is hypotension or significant hemodynamic instability, that represents anaphylaxis and should be treated accordingly. Apologize for anybody who's recently eating here.
I hope nobody
This is what's known as erythroderma. It's a non-raised red rash, often diffuse and confluent. It starts on the chest and back and spreads to the extremities and can be really painful or itchy. And again, it's sort of treated in a similar way, responds to antihistamines, steroids, but when associated with vital instability, represents anaphylaxis. It should be treated accordingly. And then again, this is not great for people eating. Apologize, but angioedema is another type of allergic reaction that can appear. It's a non-painful swelling. It can typically appear around the lips, the tongue, the uvula, or the area around the eyes. If you have somebody who's just presenting to you and you haven't seen them before, it can be useful to compare their appearance with their driver's license photo to see how has their appearance changed. I mean, and it can occasionally involve the airway, causing wheezing, or the GI tract, in which case nausea, vomiting, or abdominal pain may be a presentation here. Again, responding in many ways to similar treatment, IV Benadryl, antihistamines, and steroids, and is treated accordingly like anaphylaxis. Now that I've showed you all that, I want to put everything in a little bit of a context. This is great data that's been presented by Kevin Way, looking at the comparative risks of various strategies that we do within cardiology. And you can see that even low osmolar iodinated contrast agents, which we use all the time in CTs or in the cath lab, are associated with a risk of life-threatening reaction of about 1 in 5,000 compared to an anaphylactoid reaction of 1 in 15,000. So even though we do see reactions within from ultrasound contrast is amongst the safest of all contrast media. So because of the small risk, we have to have vigilance and preparedness for these, but it also shouldn't dissuade us from using this useful tool. And this is the data that has been published on the safety of these agents. And you can see across really 20 years of data, the largest study, which was published by the associate here, Dr. Main, is shown here in red. And it was looking at across both retrospective, prospective studies, regardless of the agent used, inpatient or outpatient setting, stress and rest, there seems to be a similar safety pattern here. In this particular study, 4.3 million individuals from the Premier Registry, looking at inpatient receipt of Definity, there was no deaths associated with it. And in fact, adjusting for somebody's likelihood of getting contrast, people were actually less likely to die within the 48 hours following the administration of contrast. This is a meta-analysis that was put together, including this and many studies, and showed that, in fact, actually, there was no significant increase in mortality risk, or a trend towards potentially a reduction in mortality with these agents, and no significant increase in myocardial infarction risk. And on the left here, you can see a study looking at 2.6 million individuals undergoing inpatient echo. A very small number of them actually received contrast, which we see quite frequently when we look at this in the literature, that it is underutilized as a tool. Propensity match for their likelihood of getting contrast, there was no change in same-day mortality. On the right is a study I mentioned to you beforehand by Dr. Main and colleagues looking at 4.3 million individuals undergoing inpatient echo and controlling for case mix. They were actually less likely to die within one day of administration. So as a result, there's been a sort of gradual amelioration of some of the contraindications around use of these to warnings, and the shunt contraindications for use have been removed as well. The theoretical concern about shunts or arterial shunts is that there could be a large clump of contrast that doesn't break up and ultimately occludes the vascular bed or placental vascular bed in the case of pregnancy. In reality, the placental or the vascular bed is so huge and these agents don't really clump together that the risk of that happening in practice is fairly low. And there's a good case series on people both administering in the setting of known shunts as well as in the setting of pregnancy without untoward risk. ASE has recommended the use of contrast agents for COVID-19. And of course, we all deal with patients with COVID, but contrast should be, plans for contrast use should be made ahead of time to avoid the sonographer waiting for the agent to be delivered and reduce the amount of struggle time. And so use is encouraged in this setting. And of course, it has been looked at as well. So this was a paper from the Mount Sinai experience looking at those individuals who got contrast with COVID. And not only was it very effective at improving image quality as we would expect it to be, but there were no adverse reactions within an hour of receipt in this small series. LVADs are a common thing that gets brought up. Is it safe to use in the setting of mechanical support like an LVAD? And of course, with the LVAD, it's very difficult to often see the ventricle. And so this was a paper looking at 2,300 echoes on 251 LVAD patients. And in general, it improved the image quality in most of those patients and actually had a significant effects on changing management in about 42% without any adverse effects on or changes in device parameters noted. Here we can see on the left an ECMO circuit. So for those who are not familiar, this is essentially a like cardiopulmonary bypass. It is supporting both the oxygenation as well as the mechanical support of the heart and lungs. And there's limited data in this setting. In general, one of the concerns is that potentially the bubbles could trigger the oxygenator a bubble alarm in the oxygenator. So the oxygenator is always looking to see are there bubbles or in the circulation, and if so, it can alarm. And so letting your perfusionist know ahead of time that there may be this alarm and that it shouldn't shut off the ECMO circuit accordingly, but that this is expected can sometimes help in preempting this ahead of time. For pregnancy, limited data are there. I've included some of the articles where this has been looked at on the upper right-hand corner for your availability. But in general, the theoretical concerns, as I mentioned, revolve around placental infarction. In general, contrast does not, which again is a low risk. In general, contrast does not cross the placenta and is not in breast milk. And it avoids the use of having to do a CT with the associated risk of ionizing radiation on the pregnant mother. And so we do this at our center under supervision and when indicated. In general, some recommendations about safety preparedness: train your staff, train your staff, train your staff. The clinical application specialists, the ICUS resources can be great in training your staff. Teach them through examples and have them repeat back these safety protocols so you know that they have understood this. And then assessing and reassessing their competency on a regular basis to say, you know, how would you respond in the case of event? Planning for the local response, the when, the how, and the who. So, for example, we started a local contrast use at a local clinic, and before we started to use it, we planned who was going to respond to an event of emergency, and what happens if that person is out on leave or vacation? What's the backup chain of command? And so everybody knows about that, that when something happens, you're prepared for that ahead of time. Having those allergy kits available and stocked is critical so that people can use them in the case of an event. And then if there are issues, tracking those issues, retaining the vial, reporting the event details to the manufacturer can be very helpful. They will have pharmacovigilance groups that go through reported reactions and documenting the reaction in the chart so that patient has a record of that going forward is helpful. And then I think really debriefing as a group on ways to improve as a group. It can be a very jarring experience. We're non-invasive cardiologists in general, so we're not used to being in a setting where we're taking on any significant risk. Again, risks are overall very low, but I think it can be very helpful to discuss as a group how to support your staff in how they think through this and ways that the response might be improved. This is what I like to affectionately call it what you really need to know about PEG. There's a lot of information and misinformation being brought up about PEG recently. PEG, or polyethylene glycol, is an excipient in the production of microbubbles to help stabilize this lipid shell. It is present in two microbubbles, Lumason and Definity, but not the third, which we use in the US, which is Optison. It's present in thousands of over-the-counter agents, including skin creams, cosmetics, etc. And in fact, about 24% of the population has evidence of immune exposure to PEG. Back in 2021, there was a little thing called the COVID pandemic going on. And when the FDA was looking at various contributions to the COVID, some of the anaphylaxis events they were seeing from the COVID vaccine, the FDA MedWatch group identified that there potentially was PEG in some of these agents, and so issued a report on presumed type 1 hypersensitivity reactions. This was based ultimately on 11 cases over the course of 10 years, with a rate of reaction being less than 1 per million doses, and none of these were laboratory confirmed. But it potentially explains some of the anaphylactoid reactions we may have seen beforehand. PEG has been in these agents since all that time when I just show you all those safety studies. It's been in the agent over that period of time, but it did result in new contraindications in those with known hypersensitivity to PEG or bowel preps. Miralax, for instance, has PEG in it. And so if you have somebody who presents to you who has had issues with PEG allergy or bowel preps ahead of time, then it does make sense to use a non-PEGylated agent in this particular circumstance. This is another sort of a paper that was brought out and specifically brought attention to specifics on contrast. And this was looked at 4 health systems of a total of 81 hospitals, and called a specific risk to one of the agents, which is Lumason. The problem is at the end of the day, only 12 hospitals were included in the analysis. It's about 15%. And it's only the 15% that had adverse events. When you include the 85% that were not included, that goes away. There are sort of differences in the weight, the dilution, and the use of the different agents and administration scheme. And there was some contemporary use versus historical use. And then dyspnea and adverse was concluded as an adverse event, and adverse events weren't really tracked prospectively. And the problem with this is, of course, we have lots of data on safety of these agents. We have post-marketing data on over 13 million patients receiving Lumason and Sonaview worldwide, and other agents as well, suggesting that while there is a risk of non-carpal reaction, that risk is low and about less than 1 in 20,000. And this is data from the FDA safety report system, looking at non-carpal reactions over the course of the COVID pandemic, and you can see that the rates are below 1 in 20,000 exposures. We have had cases of this happen, though. So if you do the math, if you do enough echoes per year and you do enough contrast, you will have this happen. So it's useful to be aware of. So we had a case of a patient who presented to our medical center with having gone in a stent, was stable overnight, got a contrast, and then immediately had chest pain and flushing. We looked at their chest. They had a rash, and they were taken to the cath lab emergently. They had ST elevations on their EKG, and you can see on the right here that they had a diffusely spasmed right coronary artery. This is what's known as Kuhn syndrome, which is an allergic coronary vasoconstriction or acute coronary syndrome in response to an allergy to an agent. It's been described with not only contrast agents, multiple different contrast agents in the past, not just, but also other contrast media as well, such as iodinated contrast. So it's not unique, but it may explain some of the more severe cases of reactions we've seen. And so recognizing that, there may be an opportunity to be able to treat accordingly if you have one of these severe cases occur. All this is underlying the real need to be able to create some consistency across labs in the safe administration of agents. And so, as mentioned earlier, this is a multi-societal consensus statement that has now been accepted for presentation and will be published within the next week or so, with really endorsements from 12 different societies across echo and ultrasound. And so we hope that this will be a helpful guidance. A lot of what I've discussed in already is in this document, but it will be a helpful resource to labs looking to grow their program. And then briefly, I want to discuss the updated data set points here. So we did a large claims study looking at contemporary safety of contrast agents in response to some of the concerns that have been raised. And here you can see this is really 21 million patients across a multi-payer data set, 2018 to 2022. We ultimately looked at those who received contrast, regardless of what type of contrast, and propensity matched them based on characteristics or likelihood of receiving contrast to those that didn't receive contrast. And I'd like to draw your attention to this slide. On the right here is the matched cohort looking at the rates of events, and you can see that really the rate of death is extraordinarily low and similar across agents, and less than that of those who didn't receive contrast. Similarly speaking, rates of anaphylaxis, myocardial infarction, VT, and cardiac arrest remain relatively low in this setting. And then when you take these individuals and adjust for the use of or the clinical characteristics, in fact, we reproduced the findings that Dr. Main found in his study here, that those individuals who received contrast, regardless of the type of contrast they received, were less likely to die within 48 hours. So I think this is very reassuring safety data that backs up the contemporary safety of these agents, and hopefully we hope that these will be published shortly. Just to underline the point, this is looking across years. So in case there was a trend in one particular year, we said, well, if the COVID pandemic is contributing to this, we want to know. And so here you can see across the agents by year, there really this is relatively flat. And so there has not been a significant rise in rates of events. And I'll leave and conclude with this one statement here, which is from the IOM. And this is really a report that they released about 10 years ago now, saying post-mortem examination research spanning decades has shown that diagnostic errors contribute to approximately 10% of patient deaths. So I'll let that settle in. Diagnostic errors are incredibly important. And if we have a tool at our disposal that allows us to be able to look at this in a safe manner and improve our accuracy and timely diagnosis, we should be using that accordingly. So thank you for your time and attention, and we'll take any questions.
Thank you so much, Dr. Strom. We'll actually continue to use your Q&A button for questions, and we'll take questions of all the faculty at the end of our time allotted here. So I'd like to introduce our second speaker. My privilege to introduce Richard G. Barr, MD, PhD, FACR, FSRU, FAIUM, Professor of Radiology, Northeast Ohio Medical University, Rootstown, Ohio. Dr. Barr. Dr. Barr, you're on mute.
There we go. All right. You can hear me now?
Yes.
Okay, great. So thank you, Matt, for that introduction. And as usual, Dr. Strom has done a wonderful job in going over the types of reactions and how to treat them and how you should be prepared. And what I want to do, and these are my disclosures, is to go over the non-cardiac uses of CEUS. As a general rule for non-cardiac CEUS, we're using a bolus technique as opposed to in cardiology where they're often using an infusion technique. And the dose obviously depends on which agent we're using. And I do want to mention we were involved in the FDA trials of several of these agents. And when we were doing those, the doses we were using for phase 2 studies was 5 to 30 times higher than the standard doses we use today. And there really were no severe reactions of a great concern when we did those reactions. So you can see even giving large doses in the past really did not lead to very many reactions. I just want to go over the literature studies that were done in the non-cardiac use. This is a really nice study from 28 Italian centers by Dr. Piscaglia. It was published in 2006. They had 23,188 investigations. No fatal events occurred. They did have AEs in 29 cases, of which only 2 were graded as serious. The rest, the 27, were non-serious. So the overall reporting rate was extremely low, as listed here. Overall, 4 AEs did require treatment, 2 serious reactions and 2 non-serious. No one was hospitalized. This large-scale retrospective analysis showed that SonoView has a very good safety profile for abdominal applications, and with an AE reported rate much lower or similar to that of radiology from CT or MRI contrast agents. Now, they were really nice because they went and reproduced this study again. So the original study was from 2001 to 2004. They repeated the study in 2021 to 2024, again, over 20,000 patients. And again, you can see that the rate of AEs and serious AEs was not significantly different than that from decades earlier. So there really was no change over time. And the second one kind of spanned the the COVID and post-COVID time period. And again, no deaths. And again, so in almost 50,000 patients between the 2 studies, there were no deaths. A large Chinese study was also published. And here they looked at the incidence of mild, moderate, and severe adverse reactions and examined their association with age, sex, body region examined, time to event, and duration of AEs in a large cohort who underwent contrast-enhanced ultrasound, again using SonoView or Lumason as we call it in the United States. This was a retrospective observational study. 49,100 patients who underwent ultrasound contrast exams were analyzed. 43 patients experienced AEs. So again, as listed here, a very small percentage, with 23 experiencing mild AEs and 13 experiencing moderate AEs and 7 severe AEs. And again, very small numbers, as you can see listed here. There were no fatal events again in almost 50,000 patients. There was no age-related or sex-related difference in the incidence with p-values as listed here. Inpatients had more often had experienced AEs than outpatients, and again, this may be secondary to other issues that are going on. And I think Jordy mentioned that sometimes some cardiac acute things may lead to an increase in minor AEs. So the mean time to event for mild and moderate AEs was 14 minutes and 15 to 16 minutes, respectively, whereas for severe AEs, they occurred quite rapidly within 2 minutes after the injection. The remission time for mild to moderate AEs was approximately 30 to 40 minutes, and all patients with severe AEs recovered within 12 hours. 21, again, 0.04% of patients did receive medical treatment, and that could have been administration of Benadryl or IVs. I just want to talk about a systematic review that we will be publishing shortly. We considered an A serious when it had a fatal outcome. It was life-threatening. It resulted in hospitalization or in a prolonged hospital stay. It resulted in disability or permanent damage. And if it required intervention to prevent permanent impairment or damage, non-serious AEs were those AEs which did not meet any of these criteria above. And again, we looked at this. It was on Lumason and Sonoview. The range of exposed patients ranged from 1 day old to 93 years old. Patient, a male and a female, almost 1-to-1. The volume and dose of administered varied from 1 milliliter to almost 15 milliliters. The speed of injection was a bolus used with a saline flush ranging from 2 milliliters to 20 milliliters. So there were 124 studies involving 694,943 patients with almost 700,000 ultrasound examinations. The rate for serious AEs, as listed here, is extremely small. And we also looked at post-marketing surveillance, which was a little higher, obviously, because people are reporting these and may not be reporting the ones that did not have it. And again, when we look for serious AEs, very, very small number of patients. And again, as listed here. So again, this review looked at almost 700,000 patients exposed with almost 700,000 exposures. The number of patients with total AEs was 383, of that almost 7,000, which gave us a 0.055%. You can see a very small range with the confidence interval there. And the number of patients with non-significant AEs was almost the same. And the number of patients that had severe ASEs was 0.003, and again, with very small confidence levels. And again, we looked at both on-label and off-label indications. So on-label indications are for liver, off-label is anything else. And again, when we look at these, almost a similar number of publications, slightly more patients administered with on-label than off-label. The number of exposures for both was approximately 6,000. And the number of patients with total AEs to the number of patients exposed, again, is listed here, a little bit higher than we reported in the other study. And the number of patients with non-significant AEs, again, listed here. And the number of patients with severe AEs, again, very, very, very small. So there was no statistical difference between the use of the agents on-label versus off-label, which, as we would expect, as the agents go throughout the whole body, no matter where we're looking at. Now, Jody talked about polyethylene glycol, and I just want to mention it too. So again, the FDA notified healthcare professionals that ultrasound contrast agents, Definity, Definity RT, and Lumison or Sonoview contain polyethylene glycol and should not be administered to patients with known or suspected allergies to PEG. Following the FDA's review of scientific literature, reports submitted to the FDA Adverse Event Reporting System, the drug sponsor safety analysis, a contraindication for PEG hypersensitivity has been added to the prescribing information for the respective agents. But be aware that we've talked about hundreds of thousands, if not millions of cases. They were aware of 11 cases of anaphylactoid with 2 deaths, which appeared to be related to the administration of one of these agents. But again, these patients did report a history of PEG allergy. So again, as healthcare professionals, we should clinically assess patients to confirm that they do not have a known or suspected allergy to PEG before administering Definity, Definity RT, and Lumison. And since patients who may not be unaware of this specific allergy to PEG, healthcare professionals should inquire about allergies to common PEG-containing products such as certain colonoscopy bowel preparations and laxatives. And we do ask the patients, but I will say that the vast majority of patients really have no idea. I believe in the last 20 years, we did have one patient that said that they had a known PEG allergy. And it's important to recognize that if you do have a patient that has a PEG allergy, Optison and Sonazoid is not available in the US, do not have PEG in their manufacturing. And again, this was started because of the possibility of reactions occurring because PEG was in the vaccines for COVID. And again, we looked at the pre-COVID versus post-COVID number of AEs. And again, we don't have a lot of published papers post-COVID compared to pre-COVID. But again, you can see here that the relative rate of reactions was very similar. And the number of AEs was very, very similar. So pre-COVID versus COVID, there was no statistical difference in the number of AEs or severe AEs. So we don't think that there has been a significant increase or change in the adverse event after the administration of COVID. So to conclude, the rate of non-serious and serious AEs of ultrasound contrast for abdominal use is very low and similar, and actually probably less than that of CT and MR. There was no significant difference between on-label and off-label uses, sex, or age. There was no difference pre-COVID versus COVID, suggesting PEG allergy is minimal. And if a patient obviously does have a known PEG allergy, pre-medication and or using one of the other agents that does not have PEG is advised. And again, although the adverse reaction rate is low, every center should be prepared to treat an AE promptly, as Jody described in his talk before mine. So with that, I'm going to end and give it back to Matt.
Thank you so much, Dr. Barr. It is now my privilege to introduce our third speaker, Casa Dargay, MD, PhD, FAIUM, FSAR, FSRU, Radiologist in Chief, William L. Van Allen Endowed Chair, Department of Radiology, Children's Hospital of Philadelphia, Professor of Radiology and Surgery, Perelman School of Medicine, University of Pennsylvania. Dr. Dargay.
Thank you very much for the kind introduction. Good afternoon, everyone, or good evening, wherever you are. It's such a pleasure to be here and to share the pediatric data on the safety of contrast-enhanced ultrasound in children. I want to acknowledge my colleague, Dr. Ekaterini Natalia, who in the Center for Pediatric Contrast Ultrasound at the Children's Hospital of Philadelphia leads our contrast-enhanced ultrasound safety studies and has contributed to this presentation and the publication associated with it. I have no relevant disclosure related to this presentation. The objective of the presentation is twofold. One, to review safety of pediatric intravenous contrast-enhanced ultrasound examinations and also the intravesical contrast-enhanced voiding urosonography, or CEUS. And I also want to briefly share the institutional data experience on safety of contrast-enhanced ultrasound at the Children's Hospital of Philadelphia. Just to start with, I want to make it clear that ultrasound contrast agents have been approved for use in children. We were very fortunate that the FDA approved in 2016 Lumason, which is known outside the US as Sonoview, for children, starting with liver, then intravesical use, and also later for cardiac applications intravenously for echocardiography. This was followed by approval of the same contrast agent in Europe for intravesical, and followed by also further approval in China for intravesical use. And last year, Definity, produced by Lantheus, has been approved for IV use for cardiac examination in children. And now the last one, Optizon from GE, we're looking forward to a pediatric application in the future. Currently, it's off-label for pediatric use. I just want to start and emphasize a few points. Ultrasound contrast agents, by the sheer fact that you use it in ultrasound, and we do a lot of ultrasound studies in children, and also we need to avoid radiation and sedation in children, the role of ultrasound contrast agents in making an impact is significant. Yeah, they are non-nephrotoxic, very important for a wide use, and you also don't need any renal function test prior to the administration of the contrast agent. Avoiding sedation or anesthesia for MRI is of great importance in the pediatric setting. It's not only about the potential harm that a sedation or anesthesia may cause, but the mere fact that it impacts workflow. And by reducing sedation and anesthesia, you improve workflow in your department, because you don't have to prepare for sedation or anesthesia or move the patient with all the tubes and lines and sedate them for MRI or do anesthesia. It is of great practical importance. Then contrast-enhanced ultrasound, even in our pediatric setting, is really a versatile modality that you can use in different settings, including administration at the bedside or intraoperatively. And in our department, we've been now using a contrast-enhanced ultrasound in children since 2013. We have established a Center for Pediatric Contrast-Enhanced Ultrasound that advances the clinical service of contrast-enhanced ultrasound, the education, and also the research in this area. This focused advancement has allowed us to expand the clinical service to various applications de facto from head to toe, including intravenously. We use it intravesical. We use it interventional. All our interventional radiologists use contrast-enhanced ultrasound for their work. We use it intracavitary in different settings, and we've been using it now for a number of years intralymphatic, all in children. So a vast array of applications. And we have seen that the ultrasound contrast agents are really well tolerated and have really a good safety records. So let me start by summarizing the information about safety regarding intravenous administration of ultrasound contrast agent in children. There is a great paper summarizing the data up to 2021, which is contrast-enhanced ultrasound by the lead author, Dr. Natalia. And here, all safety aspects in children are described, encompassing all the available literature of use of contrast with Sonoview or Lumason, Optizone, and Definity. I am now presenting you also additional data outside this publication. So currently, regarding the intravenous administration, as you can see, there are almost 80 publications, the majority as expected because it has been approved and in use in children since almost the year 2001, almost 25 years. With Sonoview, there are 73 publications with Sonoview or Lumason, 5 with Optizone, and 1 with Definity. And you can see, of course, more children with Sonoview Lumason, a total about 5,000 children and about 5,500 examinations. So how much serious adverse events are reported in the pediatric literature? We've seen that about 10 serious adverse events have been reported with Sonoview or Lumason, but you can understand there are about 5,000 exams versus 200 and 100 for Optizone and Definity. There have been 10 adverse events reported in children, which is a rate of 0.18% in the pediatric population. What are the adverse events? What are these 10 adverse events? 7 of them were anaphylactic reaction, really hypersensitivity reactions. 3 were hypotension. And most of them were acute. Within 3 minutes after injection, they required resuscitation. And all were successfully treated, no hospitalization, no fatalities. So you can see here the number of studies that had reported these adverse events, and they are from different regions of the world, mostly Europe, and you can appreciate the different age groups of children, mostly above 10 years of age. Non-serious adverse events in the pediatric literature have also been described for all these 3 ultrasound contrast agents when they are administered intravenously. And again, you see the distribution here. You note the difference at the larger group, more non-serious adverse events, a total of 56, which is a rate of 1.0% of non-serious adverse events. What are these non-serious adverse events? When we divide it by the ultrasound contrast agent here, first Lumason on Sonoview, which is 0.65%. The first one is skin mucosa symptoms, skin reactions, about 0.3. Then we have cardiorespiratory symptoms, commonly tachycardia or hypotension or hyperventilation. Then the GI symptoms with taste alteration, nausea, or neurological symptoms include dizziness and headache. Each single digit, one patient described, or other symptoms like fatigue, chills, or warmth at the injection site have all been described with Lumason and Sonoview. How about with the other contrast agents? So with Optizone, 14 non-serious adverse events have been described in 10 children that comprise taste alteration, headache, tinnitus, lightheadedness. And for Definity, similarly, the most common chest pain and fatigue. These are the non-adverse events, with 15 non-serious adverse events in 13 children for Definity. When we compare these adverse events with other contrast agent use in children, we see that with contrast-enhanced ultrasound, with ultrasound contrast agent, the rate of allergic reaction is about 0.18, and this is about 5,000 cases. When we take a dedicated CT iodinated contrast agent, this is a dedicated pediatric study, also 0.18% in about 11,000, or the MRI the gadolinium, also in a dedicated study, 0.4%. However, I have to say here, it's not only the allergic reaction we worry about, but the accumulation of gadolinium in different parts of the body, for which we currently don't have really a good explanation what's going to happen with that in the future. So in children, that is even much more worrisome because they have a longer lifespan. And like we used to think about radiation, what would happen in children in 10, 20, 30 years down the road with the gadolinium accumulation. So as my colleagues previously mentioned, it's important to have a code card in the ultrasound unit. So before we started in 2013, contrast enhanced ultrasound in our department, we didn't have a code card directly in the ultrasound unit. But since then, we have directly within the ultrasound unit a code card for eventual any adverse events where we may need to use medications to support the patient. So this is one important change one needs to make when starting to use contrast enhanced ultrasound in their department. So that's something I really encourage to even have even before the first patient. I do know a department that had their first pediatric patient and their first allergic reaction was the first patient. So you can't say when this would happen. So it's good to be prepared with a code card. In the second part, I want to describe the safety profile for intravesical administration of ultrasound contrast agent. The intravesical administration of ultrasound contrast agent has a very long history in pediatrics, having been started in the 90s in children in Europe, and since then has expanded. So it's really over 30 years now that we have been using ultrasound contrast agent intravesically in children, much earlier than when we started using it intravenously, even much earlier before the contrast agents were specifically approved for pediatric use. So regarding the safety study for contrast-enhanced voiding urosonography for detection of vesicourethral reflux with intravesical administration, again, SonoView has been much more used than Optizone and Definity, where there are no studies regarding intravesical administration. But SonoView, over 13,000, Optizone over 100. There are over 13,000 children where safety evaluation have been carried out. No serious adverse events over the past 30 years using contrast-enhanced voiding urosonography in children. Are there non-serious adverse event? Yes. And again, you see that with Lumason, with the 13,000, we saw 37 of them. With Optizone 2, so it's 39. So the rate is 0.29%. And what are these adverse events? The non-serious one, mostly dysuria, urinary retention, abdominal pain, discomfort, urine infection, anxiety during micturition, and all the others. Yeah, and they are usually self-limited, no medical intervention, and there is in this one urinary tract infection with the need of hospitalization has been described. These adverse events are comparable to that of voiding cystourethropy, which is commonly used conventional method in children, and also is comparable to nuclear studies for vesicourethral reflux. And again, it has been described that this symptom are likely related to the bladder catheter that we place in order to perform intravesical injection of the ultrasound contrast agent. I want to mention also what are really the current contraindications of ultrasound contrast agents, also that we use as much as like in the adults, in children. There are known or suspected allergy to specific composition of each ultrasound agent. For Lumason is hypersensitivity to sulfur hexafluoride, lipid microspheres, or such as polyethylene glycol. optisone, known or suspected hypersensitivity to perfluorine or albumin, and definitely hypersensitivity again to perfluorine, lipid microspheres, or PEG. These are the contraindication. But these allergies are even rare. We screen for this, but as my other colleagues mentioned, it's extremely rare. In closing, let me just share with you the CHOP experience on ultrasound contrast agent safety. As I mentioned, we've been using contrast agents starting 2013 with intravesical, then 2016 with intravenous, and have done quite a significant number of studies. We have over 2,400 exams in children, intravenously 1,400, and contrast-enhanced voiding urosonography, about 900 other applications, intracavitary. And we have a center for lymphatic diagnosis treatment. And my colleagues in the interventional radiology and also in the lymphatic center have really perfected contrast-enhanced lymphatic examinations for various indications. So we use that commonly in our department. So up to date, from 2016, when we started intravenous, before that it was only intravesical, as mentioned, these are the total number of exams. We had 2 serious adverse events, and this is 0.14% of examinations. And these adverse event were allergic reactions. The patients were treated, they were not hospitalized, and they were released in good status. We did a joint study with Johns Hopkins Department of Radiology with a focus on critically ill patients. These are ICU patients, patients in the neonatal intensive care unit, pediatric intensive care unit, and pediatric cardiac intensive care unit. All very sick patients, all with tubes and lines, ECMO, and all that. And we looked at the rate of adverse events when we administer contrast-enhanced ultrasound in these patients. You may ask, why would you administer in these patients more? Yeah, these are the very ill patients. These are the patients we don't want to transport and do bedside studies. These are the patients that suffer from hypoxic changes in the brain. We want to see the brain. We do brain contrast-enhanced ultrasound also. These are the patients who may suffer from necrotizing enterocolitis, so we do bowel ultrasound. These are patients who may have thrombosis somewhere, and then we want to see. These are patients who may have ischemic changes that involve the kidneys or other organ, and we want to see. And so we use contrast-enhanced ultrasound in these very critically ill patients. We did a thorough study in this, monitoring the patient and looking at various outcomes, and we found no clinically significant adverse events in these children too. So that is really very encouraging in terms of the use of contrast-enhanced ultrasound in a broad spectrum of pediatric patients, which incorporates all age groups in our patient population. So in closing, I want to again emphasize that the ultrasound contrast agent in children is well tolerated, has a high safety profile. Serious adverse events are rare. Non-serious adverse events with contrast-enhanced voiding urosonography are related probably to the catheter. We should not forget the many benefits of contrast-enhanced ultrasound being non-nephrotoxic, the accessibility, portability, the quick examination, the opportunity to eliminate sedation and anesthesia, which has medical impact, but also workflow impact. So in closing, I just want to say that the benefits of ultrasound contrast agents in children far outweigh the risk concerns. Thank you very much for your attention.
Thank you so much, Dr. Gargay. Very, very good talks. I will now hand it over to Dr. Main to lead our summary and Q&A session.
All right. Well, thanks to all three speakers for, as Matt just said, really outstanding talks on this subject. We have a few questions that have come in through the Q&A. I'd like to encourage others to submit their questions on Q&A. And we do have some time left over to address some of those. We start off with a question about this idea of allergy kits. And Jordy, you kind of led the discussion on that. Others commented as well. Why have a separate allergy kit versus a code card? Maybe just a little bit more on what you put in that kit and when to administer which drugs. Obviously, the EpiPen is a component of those. When do you administer epinephrine? There's always some trepidation about that, particularly in cardiac patients. But maybe Jordy, lead off on that, and we'll hear from Casa and Richard as well on that topic.
Yeah, thanks. I think it's a really good question, and I think the assumption is that sometimes that our allergy kits are equivalent, but in fact, actually, there's some differences, and it depends on what you put in your allergy kit ultimately. But we routinely keep things like a IV start kit, bags of saline, a pressure tubing in case we need to give saline fast. We have famotidine and others, H1 and H2 blocker, Benadryl, IV Benadryl, which may or may not be, most, I should say, code cards do not routinely have antihistamines as part of that. And then the EpiPen, we have also as well, and again, is a different concentration and dose compared to that which we give in the case of ACLS. Where you're giving a sort of a milligram of a very high dose, a high concentration of epinephrine. So those are sort of the big things. I'm certainly happy if there's a way. I know that some people had requested that we send them the contents of that. I'm sort of happy to share that if that's feasible. But those are the large things. And the other thing I think is you don't want to have to break into your code cart if you have an event. So it helps reserve the code carts for the code. And if you have allergy kits, you could potentially place them in places where you otherwise don't have the space or room even for a code cart. They're portable, so you can take them with you if you happen to be injecting in a different location, as opposed to the code cart, which can be somewhat unwieldy. So I do think it's a worthwhile investment. It is a different investment. It's not something that routinely sort of hospitals carry around for the most part with them. And then, if your pharmacy permits it, you could do several different things. You could have it as an actual cart, stand aside bin, or you could have it as part of your Pyxis or some other sort of Medicaid MR, and that can be helpful as well.
All right, that's great. Richard, Casa, anything to add to that discussion or comment?
I understand what Dr. Strom is mentioning. In our case, a lot of these code cards are standardized throughout the hospital, and everything has to be the same. Every follow-up and control has to be the same. I do understand to open a code card and then to have to reset it may be a little cumbersome, but also the fact that these reactions are rare helps us, but you still have to maintain and ensure that everything is not expired throughout. Yeah, but I think the standardization and having the same throughout, and also the fact that the code team coming from different places needs to have the same thing available is important. So in our setting, we just follow that procedure.
Yeah, so we're a little bit different because we're an outpatient facility. And our CT department and MRI department and ultrasound department are not that far from each other. So we have one crash cart that's shared between all three modalities. We are not attached to a hospital. So we are all ACR or ACS certified for resuscitation. And unfortunately, if we do have something that's really bad, we have to call 911 and the patient has to be transferred to a hospital that's a couple miles away. We've not had a problem with that. I will say we have a lot more reactions on CT and MR than we do with ultrasound, and we had to send a few patients to the emergency room from MR over the last couple of years. We've never had to send one, I think, from ultrasound contrast.
I just wanted to add to that, the protocol is really important too, just making sure that people know where the cart is, or if you have it's not useful to have an allergy kit if you don't know where it is and your staff can't find it. And so the important part is having something that's available, accessible, but also that people know about. And so for our lab, what we do is we keep allergy kits in each one of the echo labs that we have, and several across different sites, geographically disparate. But we also have a sort of little cheat sheet that's posted on the machine itself, a little card that goes through what the workflow is for contacting people in the event of an emergency, so that it's never very far for people to reach to, and that you know I think the natural tendency is for a lot of people to panic in the individual circumstance of what's going on, and to the extent that you have something right in front of you telling you what to do and in what order to do that, it can be really helpful. So we have deputized our fellows, and have said basically this is like a STEMI. If you have you can carry a bubble pager, and if the bubble pager goes off, you drop everything and you run to support the sonographers, and in that way we ensure that the sonographers feel supported, that there's ability to be able to respond when something does happen, but also at the same time that allows for according and appropriate use.
Right, great. Those of us who've been doing this for a while, which includes all of you, will remember back in the time frame 2007, 2008, the FDA actually mandated a 30-minute monitoring period after administration of ultrasound contrast agents. That has since been rescinded, but we do have a question from the audience on that. What are the panelists' impressions on whether or not that's necessary based on when these adverse reactions typically occur?
So if the patient does not have any reaction, we let them go immediately. If they do have a minor reaction, we often watch them for 20 minutes and make sure they're stable before they go home. I think we've had one or two people that have had more severe reactions that we've had for maybe an hour, and watch them and make sure that their vitals are okay before we send them home. Like I said, we've never sent anyone to the emergency room or to the hospital from these reactions. We've managed them all there. The other thing I'll mention is the American College of Radiology has a really nice sheet of how to treat all these reactions and what you should use and how you should use it. And we have that posted on the wall where these patients would be, where we're treating them. So that's really available for us, everyone to see what is appropriate to use. We find that very, very helpful since we don't deal with this very often.
Yeah, I would add to that. Most of these reactions are nearly immediate, or within a minute or so of the administration. So they really do occur right away. And for the sonographers who are in the room, it can be very helpful if somebody is complaining to you of something funny, just to turn on the light and bring the robe down, look at their chest, do they have a truncal rash? That can be really helpful. But in terms of monitoring them, we don't routinely do that for 30 minutes. If somebody does have an anaphylaxis reaction, there is the possibility in anaphylaxis of having a sort of a biphasic reaction, that they can have a delayed reaction as well as the sort of acute reaction. And so in those cases, and that's part of what the steroids actually help to prevent, is that secondary sort of biphasic reaction in the case of the things. So if somebody does have anaphylaxis, for sure they're treated accordingly, and then they're brought down to the emergency room for monitoring and to receive steroids if they haven't already.
When it comes to pediatric examinations, I can say maybe over 2 decades ago, we used to keep the children for half an hour or so to see them, but that has been abandoned long time ago. So after any contrast-enhanced ultrasound examination, after the study is done, the patients are released and go where, if it's outpatient, or go back to the ward, the inpatients. If a patient has some minor reaction, we may watch the patient a bit longer, but not really have a defined long period of observation. The two patients that we had with the allergic reaction, I mean, it happened in our main hospital where we have an emergency department, so we sent them there. They observed them for a while, and then they send them home. Yeah, because we just have that facility, but we don't keep them in the ultrasound unit.
So consensus that we really don't need to engage in prolonged monitoring of these patients on a routine basis. Also, I'd make the point that it is possible to have an anaphylaxis or anaphylactoid reaction without skin changes. It can present just with vascular collapse. So be on the lookout for that, and remember that absence of any early skin findings does not preclude the possibility that it's a serious allergic reaction if the patient does have vascular collapse. What do we know about the route of administration and the dose of administration of these contrast agents with respect to likelihood of having a serious allergic reaction? Jordy, you want to start off on that one?
Yeah, actually, I think you have had you and I have had conversations about this beforehand, and you've really published some really seminal work on this. That perhaps there is a sort of a dose relationship in terms of the peak bloodstream concentration may be related. Again, hard to know. These events are really infrequent, and so to study them and to study the dose and concentration and all that is very challenging. But anecdotally, there has been some thought that perhaps diluting the agent out and administering it slowly, sort of a slow bolus or infusion, we could have a temporizing effect on the rate of reactions. It seems to be we're all in a rush, and we want to move on with the patients, but I think at slow injection, and then for those who are not familiar, dilution is very common for these. Oftentimes, the amount of contrast that's given as part of the contrast agent, or even on the label, is a lot more microbubbles than are needed for imaging. And so we routinely dilute basically sort of 1-to-1 with saline and administer a small portion of sort of a low amount. And whatever is needed for a full pacification, if we need to give more, we give more. But we only use the dose that's necessary, and follow it up with a slow saline chase.
We were doing phase 2 trials for DEFINITY, and one of the doses was 9 cc's. So our standard dose now is 0.3 cc's. We were giving 30 times the dose, and I will say that those people did have more back pain problems when we were giving those higher doses. We never had a serious adverse event, but there was this short-term low back pain. In radiology, it's really important for us to look at that arterial phase and the timing. So we don't like to dilute things, and we like to have a pretty nice bolus for us to see that arterial phase, and that's really important. So I think the machines have gotten so much better that we are using very low doses compared to what we used 10 years ago. And like I said, we really have it. And I think another thing we really didn't discuss is a lot of times if the patient is a nervous wreck, they're more likely to have a reaction. And if they feel calm and they're not worried, and we try to talk to them and make them feel comfortable, it's very unlikely that they will have some of these reactions.
So in pediatrics, because the FDA-approved dose for pediatrics for intravenous use is 0.03 ml per kilogram, you can just imagine how little doses we use in children. So if you have a 5 kilo newborn, you can imagine it's about 0.1 ml. And the saddest part is you use 0.1 ml and throw away 4.9 ml of contrast in the vial because we can't use it for the next patient. But we use very small amount of contrast in the children in all routes of administration. And then, as Dr. Barr mentioned, because in a lot of the exam, we need to see the arterial phase. We want to have a bolus and then a normal saline flash. So the doses are already so small that I mean, I'm not sure we can even appreciate the difference in bigger doses. And we have to say that the adverse events, the serious ones, the 2 cases, are only with the intravesical administration. We have not seen that with intravesical, intracavitary, and our interventional radiologists use it in various applications. For procedures they haven't, and our colleagues using for intralymphatic use have not seen it. Yeah, they use it intralymphatic to inject directly through the lymph node or to inject through the lymphatics of the liver or the mesentery, but they have not seen such adverse events. So I think it might be related to intravenous use. I cannot say very much about the dose effect because we use very little volume of contrast. And we do have to remember about an ml of Lumason has about 600 million microbubbles. So a half ml has 300 million. So there's a lot of microbubbles in these tiny amounts of ultrasound contrast agent.
All right, great. Richard, you brought up back pain or flank pain that sometimes occurs with administration of ultrasound contrast agents. What do we know about the etiology of that? Is this part of the allergic reaction cascade? Is it part of the CARPA reaction? And then I guess secondly, do we need to monitor these patients? Would you administer contrast to them on subsequent imaging attempts?
So I'm not really sure I understand why they have back pain. Again, it seems to be with larger doses, and the question is, are the bubbles affecting the vascular supply? The pain usually lasts for less than 1 minute, so it's gone before we even finish the exam. We do not mark or flag the patient that they had a reaction and have no problems with giving them doses again. I think it's not anaphylactoid or a reaction. I think it has something to do with somehow the bubbles doing something maybe to the vascular system. I must say now that we're using much smaller doses with the newer equipment, we rarely even see that.
And I would also bring up that diluting may seem to help this because, again, for the issue that these are related to larger dose, potentially related to larger doses, and so but diluting may have some effect into reducing the incidence of it. The other thing that I've heard from people anecdotally in treating this has been if you take an ultrasound high MI probe and actually put it on somebody else's back, there's the theoretical benefit of breaking up those microbubbles, and maybe that leads to some degree of faster resolution. I don't, there's no data to support that per se, but it is a practice that some labs have done accordingly, and it's not serious.
Well, Jordy, we'll stick with you on this one. You presented some data that show that when you propensity match patients who've received contrast versus not, there actually seems to be a lower mortality rate at 24 hours. And I think as far as we know, there's no therapeutic benefit of microbubbles, at least in this context of imaging. So how might we explain that? What are some of the potential mechanisms that could account for that?
Yeah, I think it's a really good point. And I think it's important to recognize that the people who get contrast are different from the people who don't get contrast. And there's a decision that's made by either sonographer or a physician or nurse to administer the contrast. And because of that, these people are different. And we saw that in the data as well, that if you look at people, for example, getting contrast, oftentimes they're much more frequently in inpatient setting or emergency room setting that they compared to people who don't get contrast. And they may have other comorbidities that contribute to their need for contrast, the rate of suboptimal image quality, either metabolic conditions or others that associate it with their challenges and challenging echo windows. And so, bless you. So for all those reasons, I think we're not really doing a full apples to apples comparison when we compare it sort of naively without that adjustment to people who get contrast to people who don't, because they're different. So when you do adjust for it, you seem to see a more protective benefit. Now, how much of that is related to other factors of care, the sites that are using contrast or the other contributors, it's hard to say. I mean, it is certainly possible that contrast could be related to a more clear diagnosis, and so therefore you have a better, earlier timely diagnosis, and therefore that's the mechanism by which mortality is reduced. But it also is possible that we're dealing with just a different animal. The people who get contrast are different than people who don't. What I do think is that the finding. So I wouldn't go out and say, contrast necessarily is saving life, although I personally think that. I don't know that we have the data to show that. But I think that it certainly indicates that there's not a significant excess risk, and that's the reassuring part. Is we really should take from this is the risks are low.
Very good. I recall a study that we did in our lab. This is about 15 years ago now, comparing. It was not propensity matched. It was just a retrospective review looking at folks who received contrast as an inpatient versus those who did not. And the 24-hour mortality was 0.4% in both arms. And I thought what was striking about that was the fact that when we're imaging patients who've been admitted to hospital, about 1 out of 200 will die within the next 24 hours. Just speaks to the acuity of these patients that we're imaging every day. So I thought that was a very interesting finding. We have a question regarding relative risk amongst the 3 commercially available contrast agents. There was a paper I know published recently in the AJC that purported to show a significant difference between agents. And I'd just like to ask the panelists, based on the available data, what are their thoughts on this? Are there differences between the agents, or is this largely best viewed as a class? Anybody can take that, whoever wants to start off.
I just want to mention the pediatric experience is limited, so it's really hard to say anything specific. As I showed you, the numbers, the use of Optizone and Definity intravenously are very limited, and intravesically also we have Optizone, a small study, and no Definity study. So these are really difficult to compare. The most commonly one that is used is Lumason or Sonoview.
Yeah, and I would add to that. I think it's challenging because there's different ways in which these agents are used. We typically see, for example, that Optizone is used more frequently in the outpatient setting, whereas Lumason, Definity more in the inpatient and ED setting. So the patients that are getting them are a little bit different. In general, the number of adverse events for all these agents are incredibly low. So it's difficult to make sort of cross comparisons across different agents in terms of the relative safety, because the safety of all of the agents is low. And when that has been looked at, and we did look at that in our paper as well, it seems to be a wash, that all of the agents seem to be associated with a low risk, and that there doesn't seem to be a particular agent that stands out as safer.
So over the last 20 years, we've used all 3 agents over the time, and we've never noticed a difference between adverse events between all 3. And over that time, again, we used a moderate amount of all 3 agents, and we've not seen it. And again, the rate of reactions is so low. You need so many people to actually do a study to see that there's a significant difference. I think it's hard, but our experience is it doesn't matter what agent we use. The adverse event rate is identical.
And while on the topic, I just wanted to bring up the idea. I mean, somebody's personal experience and the personal experience of a lab may be slightly different than what we're seeing in the published literature, and that's the reason we need to do the studies, right? Is because everybody's experiences within their viewpoint. We want to look at across labs, and it's not as simple as you do 10,000 cases, you have a contrast reaction. You can have times where there are clusters of cases where there are back-to-back events, and it can seem like there may be an increased risk in that particular agent or otherwise. but the reality is you may have a cluster of cases, and then you may have years and years and years where you don't have any issues, and so it balances itself out in the net. And for whatever reason, we do tend to see that these sort of when they do happen, these adverse events can sort of cluster, and I think that's just purely statistical chance.
Yeah. There is some evidence, I think, in the radiology literature suggesting that some of this can cluster at certain times in the year, particularly in atopic individuals who are predisposed to allergic reactions in the fall and spring allergy seasons. There can be some clustering or peaking of these types of events as well. So a lot yet to know about that, but would totally agree. Last question that I just throw out to the group comes from the audience. They understand that there doesn't appear to be much evidence to suggest an increase in rates of these reactions post-COVID, but they've certainly noticed that in their lab. Any comments from the speakers on that?
Yeah, I can feel that one. I think this is directly related to what you were just talking about. Speaking to several of our allergists in the area, and again, I don't know great literature to support this, but there seems to have they have noted an increase in allergies overall in the setting of COVID. And that it's not specific to contrast agents, but they certainly see a rise in allergic reactions overall. And I think part of at least with the discussions that I have with them, is it seems that the allergic diathesis or predisposition to allergy can be sort of triggered by viruses and other sort of immunologic triggers. And so it's certainly possible that maybe because of COVID and because of the experience that we all had as a society, that we're seeing a little bit more now than others. That being said, the data doesn't suggest that. The data suggests that we're seeing essentially a fixed and flat rate of reactions, and perhaps the reason anecdotally that people are seeing this more is because we're also using the contrast agents a lot more than we were in other settings and in expanded indications. And as these agents get used in a much wider variety of patients, we're likely to see the rates of those increase.
Very good. Well, I'd like to thank all three speakers for really outstanding presentations, a lively Q&A session. I think we've answered a lot of great questions from the audience and others. And with that, I would turn it back over to Matt for some housekeeping and closing comments.
No, Mike, before we leave, I don't think
Yes.
we mentioned that at the last ICUS meeting, we had a roundtable about safety, which was filmed and is available on YouTube. So that's another area, if you have some interest, to Google ICUS on YouTube. And it's several of us that are actually on this panel and several others that discuss their feelings about safety. And it covers a little bit more, I think, than what we covered here, including pregnancy and how there was a more international panel, how they handle stuff. So that'd be another area if you would like to look at things a little more in depth.
Great mention. Thanks, Richard.